Good morning to everybody. I'm very happy to share with you our experience in PFO closure. We will show you here a very nice clinical case with some troubles to travel the PFO, and you will see how we deal with this difficulty and how to manage particular PFO anatomy. I wish you will enjoy this video, and I'm wait for your questions or any particular comment or any question. So goodbye, and let's see together the presentation. In the beginning, we can say that PFO is non-Rahab effect due to non-fusion between the primum and secundum septum. It's responsible of transitory right to left atrium shunt. Its prevalence is around 25% in general population. During pregnancy, foramen ovale is important for fetal circulation, and after birth, it will be closed because of left atrium pressure elevation, and then it will be histologically closed because of fusion between the primum and the secundum septum. The PFO diagnostic is made accidentally or after an embolic event as a stroke. The transthoracic echo has a sensibility of 46%. The transesophageal echo is the gold standard in this diagnostic. When to close, the first closure indication is cryptogenic stroke. To be sure that the PFO is responsible of the stroke, you have to calculate Rope score. It gives the accountability of the PFO based on few items. You can see it here. For example, we can give an algorithm. In situation of cryptogenic stroke with PFO, we have to see in the beginning the age of the patient, less than 60 years old, with large right to left shunt or an atrial septal aneurysm. The PFO closure is the main indication. In patient less than 60-year-old with mild to moderate shunt with a Rope score over 5, the PFO closure is indicated also. And in patient less than 60 years with mild to moderate shunt with a Rope score less than 5, we can also consider the PFO closure in that situation. For patient over 60 years old, the medical treatment is the first option. The second closure indication is platypnea orthodoxia syndrome, characterized by a dyspnea in orthostatic position with hypoxemia, which disappeared in clinostatism. The procedures seem to be safe, with few complications as puncture site hematoma 3 at 5%, device clotting or embolization, atrial erosion, stroke, or tamponade. Now, what's about treatment after PFO closure? All patients must receive a double antiplatelet therapy for 1 to 6 months, and then we can stop one of the antiplatelet therapy and maintain aspirin alone for at least 5 years. Non-tibio prophylaxis must be given for the 6 first months if the patient has any invasive procedure. For the follow-up, we can control the patient at 1, 3, and 6 months with only clinical examination, EKG, and transthoracic echo. The transesophageal one is indicated in case of suspicion of dislodgement or clotting of the device, if we suspect an infective endocarditis, or in case of new stroke. Let's see together now our second clinical case. It's about a 41-year-old male with cryptogenic stroke. He is a smoker, and we discover a PFO on his transthoracic echo, measuring 1 millimeter of diameter and 6 millimeter of length. His Rope score was at 7, so according to our algorithm, we decided to close this PFO. For device sizing, majority of PFO are sealed with a 25 millimeter device. The 35 millimeter device is used only if we have a long PFO with length over 15 millimeter, lipomatous hypertrophy of septum secundum, or an atrial septal aneurysm. The 18 millimeter device is rarely used because of the partial closure or dislodgement risk. So for this patient, we choose to use a 25 millimeter device, and let's see together the video of all the procedure, and we will meet after the procedure to debrief and to answer a few questions. So I wish you a good video, and we will see after. Bye bye.
Hello everybody, good morning. Nice to meet you and very happy to receive you in our cath lab. We are in the first cath lab dedicated to coronary artery disease and structural heart disease. We have a second cath lab dedicated to electrophysiology, and we are close to the surgical department, which is at 5 or 10 meters from us. I'm very happy to introduce you my team. Dr. Boukabous, she will work with me in the invasive parts of the procedure. Dr. Boukdour, she will be responsible of the echo, and we have Dr. Derwish, who is a cardiac surgeon. He will work with us outside. I'm very happy to introduce you to my nurses. I have with me Mr. Akli Massinissa and Mr. Maouch Mohammed. We are dealing today with a patient with PFO and cryptogenic shock. We are dealing to close this PFO. So we started a few minutes before. We punctured the femoral vena, as you can see, with 7 French sheet. And then we put 1 cc of heparin. We are dealing the procedure under heparin that we put after the puncture. And now we will start by putting our MPA catheter. You can see it on paper. It will travel the PFO and making easier to go easier to go to the left side of the PFO. Donc encore une fois bonjour, bienvenue. Nous sommes dans notre principal cath lab. Je vous ai introduit mon équipe, je ne vais pas les réintroduire une nouvelle fois. Donc la procédure se fait, comme je l'ai dit, sous héparine. On a ponctionné la veine fémorale droite avec un désilé CTF. Nous avons par la suite mis un cc d'héparine, et là la procédure va commencer tout de suite. Donc avec la sonde MPA, on mettra un guide classique en J035 qui nous permettra de traverser le PFO et de passer du côté gauche de ce PFO. C'est un patient, je rappelle, qui a un PFO avec un AVC cryptogène. So if you can maybe film the pull back, please. Push, please. Push the white. Okay. Maybe we can zoom a little bit. Let me just give you zoom, please. Now I'm trying to travel the PFO. Sometimes it can be difficult. It depends from the diameter of the PFO. So the most important is to be in the right atrium and then turn to be close to the PFO and push your wire or push your MPA. It's our second case of today. The first one, it was very easy. We performed the procedure during maybe 20 minutes from the beginning, from the skin to skin. I hope it will be the same now. Donc, comme je l'ai dit, c'est notre deuxième cas de la journée. Le premier s'est déroulé très facilement, donc on a pris pratiquement 20 minutes peau à peau. Le franchissement, comme je l'ai dit, je dois me mettre avec la MPA au regard du septum et je dois un petit peu pousser pour pouvoir franchir le septum interauriculaire. On voit qu'on a des petites difficultés. Je ne sais pas si je ne suis pas exactement au regard du PFO. On va essayer de changer un petit peu la position. Et puis, not with the G-type wire. If I can have non-G-type wire. Guide droit, non JT. Celui que tu m'avais proposé tout à l'heure, je pense qu'il est avec le plateau. Non, pas le rigide. C'est un guide non JT. Je peux prendre le guide s'il te plaît. Vous l'avez déjà proposé, donc on avait préféré de prendre le guide en J. On va essayer de prendre un guide droit pour essayer de mieux franchir. Ouais. Je vais le prendre. Je l'avais pris au départ et ensuite je me suis dit le guide en J sera pour la première patient.
Merci.
Can we have Judkins, please? Here. JF. Now I'm trying to cross with the Judkins right. Maybe if I will be able to cross, to be honest scientifically, maybe I will cut this part. I will show that just that we can cross under MPA and then we change it with the GR to make the video smaller. Give us a better contact. Maybe not a good one, but better contact. It's very interesting. We failed to cross also with the Judkins right. I'm thinking about using the Mullins introducer. Use it to perform septal puncture. And we have it's dedicated to be close to the septum. Donc, comme j'ai dit, c'est intéressant parce qu'on voit qu'on ne franchit ni avec la MPA ni avec la Judkins. Ouais, s'il te plaît. Et donc, je suis en train de réfléchir à prendre une Mullins qu'on utilise d'habitude pour réaliser des ponctions transseptales. Elle a une courbure qui nous permet de se mettre directement au contact de la fosse ovale et de pousser ici. Théoriquement, on va franchir. Ça ne sera peut-être pas avec le 0,35, il faudra un 0,32. C'est ce qui rentre dans la Mullins. Mais on va voir, c'est intéressant. On va voir ce que ça donne. So, after failing to cross with the MPA and with the Judkins right, we think to use the Mullins sheath that we present like this with the dilatator. We have here a G type that would be maybe directly in the contact of the septum. Donc après avoir échoué sur une Judkins droite et après avoir essayé la MPA qui est la sonde classiquement décrite pour le PFO, on est en train de penser à franchir avec la gaine de Mullins qui nous permet d'habitude de faire des fonctions transseptales. Elle a une courbure qui permet d'être au contact du septum pour fonctionner. Donc on va essayer de se mettre au contact du septum et on va pousser avec un guide 0,32, on va voir. So remember that you have to use a 032 wire with the Mullins, not the 035. Okay? So you have to change your wire. I have to pull back the catheter here. No. Yeah. You have to put the 032 in place of the 035. And then pulling back the 7 French sheet and put the Mullins one in its place. It will take a few seconds more, so if you want to go to drink coffee, it's okay for me. You have to come back in 2 or 3 minutes. Okay. Can I have the Mullins, please? Donc, comme vous avez vu, la Mullins monte sur des 0,32, donc il fallait changer le guide 0,35 par un 0,32, retirer le visier 7F et monter avec une Mullins. J'espère qu'on pourra avoir le contact désiré et qu'on pourra franchir. Point fixe. Tire un peu le guide. On va peut-être agrandir un peu le trou. Donc pour ceux qui font du transseptal, la Mullins, il faut mettre 0,32 dans la même capsule. Et après, il faut descendre progressivement pour être certain de toucher le septum comme on le veut, de caresser le septum. So you have to put your 032 in the superior vena cava, and then pulling back the mullins. Be sure that you are in contact with the septum. No. No. I know exactly where I am. Can you see in the echo? Maybe we cross, but I have to check in the echo if you are in the left atrium. Yeah, of course. You have just to check in the echo that we cross the PFO. Seems to be a high position. Yes, we are on the right edge of the heart. Yeah. Sure. Yes. How the wire will stay in place. Can I have the 7 French sheet here, please? Ok. J'ai tourné ma sonde, mais bon, comme vous pouvez le voir, ça part plus longtemps dans le truc. Ouais, super. Donc là, descendre un peu le tube parce qu'on avait remonté pour zoomer. Donc, as you can see, now we are in the pulmonary vena. It was not easy, but maybe it's interesting for those kind of cases. It's a learning case, so you have to see if you have any difficulty, how to deal with it, how to change your strategy, how to use your material. And here you can saw that we start with the MPA as it's described in a classic procedure. It was impossible to cross with the MPA. We used the Judkins right, and then we used the Mullins sheet, and it was easy to cross with the Mullins sheet. Now I have to use my stiff wire, on 35, to stabilize the delivery system. Slowly, I have to push it in the pulmonary vena, and then I can retrieve my MPA. Donc comme vous avez vu, on a eu des difficultés, on n'a pas pu franchir. C'est bien pour des cas de learning. Ça vous apprend à dealer avec votre matériel, à changer, à sortir des sentiers battus qu'on avait tenté de franchir avec une MPA. Ça n'a pas marché, on a changé avec une Judkins en se disant que la courbure allait nous donner un meilleur contact avec le septum et qu'on pouvait pousser sur le foramen. Ça n'a pas marché. Ensuite, bon, on a pris la Mullins qu'on a appris à utiliser pour le transseptal. On fait énormément de transseptal pour la dilatation mitrale. Donc on a adapté un petit peu nos connaissances. Bien sûr qu'on n'a pas fonctionné. On a mis juste le guide 032 sur la Mullins. On a poussé et ça a permis de franchir. Ensuite, il fallait toute une gymnastique pour à nouveau faire remonter notre matériel, notre 035 qu'on a mis dans la veine pulmonaire, le changement de pression. So here you have the delivery system. The device house, la maison de la prothèse. Prepare it like this. I have to push. Can we flush, please? Yeah. So I retrieve the 7 French sheet. I put the delivery system sheet on its place. I will push it till the pulmonary vein. Donc vous allez voir le delivery system qui arrive. Je dois stabiliser mon guide, je pousse un petit peu. Now I have to push it and maintain the wire in place to be sure that the delivery system will go on the pulmonary vena. Here it is, and it's okay. I have to pack everything now. Film, it's okay. Can I have the syringe to flush a little bit? Thank you. It's okay for me. Now we are asking for the device. Est-ce qu'on peut avoir la prothèse? 25 on 25. Is it 25 on 25? Okay. Okay, it's good. Let me show you the device. This is the PFO closure device with 2 discs, and the central part is 25 on the left atrium disc, 25 on the right atrium disc, and the central one is small and it's 33 mm of long. Donc ça c'est la prothèse. Vous avez le disque auriculaire gauche qui fait 25 mm, le disque auriculaire droit qui fait 25 mm, la partie centrale qui va se mettre dans le PFO qui est fine et qui fait 3 mm de long. Donc on la plonge dans le sérum. You have to put it in the salina and to fix it on the delivery system I have to turn clockwise. Donc je la fixe, je tourne en horaire. Horaire c'est ça, c'est-à-dire la prothèse va tourner dans le sens des aiguilles d'une montre. When you arrive in the last turn, you have to turn back for few degrees. Quand vous arrivez à bout, en général elle est très serrée, donc vous devez revenir un petit peu de quelques degrés, vraiment, il ne s'agit pas de la désenclaver, mais vraiment quelques degrés pour faciliter le largage. Now I'm pulling back the device under flush to avoid bubbles. It's okay, donc je vais la retirer sous flush pour éviter les bulles. Go here, go here. It's okay, it's okay, it's okay for me. Flush, 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 flush. It's okay. Now you can see the device in its house. There is no bubble. Flush second time, please. Okay. It's perfect. Now we have to go here. Et comme vous avez vu, la prothèse est à l'intérieur, il n'y a pas de bulle. Là, on va flusher. Parfait. It's okay. Maybe I will have a little friction. On peut ressentir un peu de friction. Je vous rappelle que c'est une 25 qui rentre dans un désilé 9 ou 10 French. Nous, on a opté pour le 9, qui est la limite inférieure, so maybe you will have little friction. It's not important. It's very easy to push. You will see it coming. Vous allez voir la prothèse qui va venir dans le système. Can we have the echo, please? Now it's your turn, Mr. Boudou. Here I am in the left atrium. I have to push the left atrium disc. It's okay. It goes out. I have to pull back everything to be in contact with the septum. Here I am in contact. You can see that the device is disformed. So I'm pulling back more. I'm waiting for the echo. Donc là, comme vous avez vu, on a fait ouvrir le disque auriculaire gauche qui s'ouvre très bien, c'est-à-dire qu'on n'est pas dans la veine pulmonaire. On retire un petit peu et donc on le voit se plaquer sur le septum. On fait un petit mouvement de traction, on va voir la prothèse qui se déforme, ça signe qu'elle est vraiment au contact du septum. On attend que l'échographiste nous donne la position échographique et puis on maintient la prothèse en traction et on largue le deuxième disque. Là je vois l'écho, donc je vois que je suis un peu loin du septum, donc je peux descendre un petit peu plus. Voilà, là je suis vraiment au contact du septum. Et donc je maintiens la prothèse et je tire. Là j'ai l'impression d'être bon. Et donc en angiographie, tu peux montrer s'il te plaît? En angiographie, donc comme vous pouvez le voir, on a les deux disques qui sont largués. On a l'impression d'être bon. La prothèse est encore un peu déformée parce qu'elle est tirée par le delivery system. Maintenant on attend la réponse échographique. On va voir en ETT si la prothèse est bien, on va voir en ETO aussi si la prothèse est bien. On peut même faire une contrasto à travers le delivery system pour voir s'il y a des bulles qui passent. C'est pas très grave si les bulles passent durant la procédure. On aura une thrombose de la prothèse, on fait ça sous héparine, une thrombose progressive, puis une endothélialisation qui va parfaire la fermeture. So now we have to wait for the echo, the thoracic and transesophageal echo that will say if we are in the right position, and we can perform a bubble test. We can push the bubble on the delivery system, and we see if we have bubbles that go in to the right, to the left part of the heart. What we call bubble test, the test au bulles. Maybe sometimes in the first minutes or hours of the procedure, you can have few bubbles that go in from the right to the left. It doesn't matter if it's not very important, because you are working under heparin, so maybe the prothèse will clot after and will endothelize after. Je soulève un peu le tube. J'ai l'impression d'être bon, tu me diras. Je fais de l'ETO aussi, s'il te plaît. Now we have bubble. There is no bubble going to the left side of the septum. Seems to be totally sealed. I have to try again. Can we try again?
Yes.
Okay. Make bubbles. As you can see, the defect seems to be totally sealed. You don't have any bubble going to the other side of the septum. Do you agree?
Yes.
So, patient seems to be quite numb. We can take our time to make a small sealing. See the device in other angulation. T. It's okay. Seems to be okay. You can see that we catch the septum. It's okay. Perfect. Now, if you can come back here, Mohammed, and film both screens. I'm going. No bubble, huh? Right? No bubble going to inside the PFO. So maybe it's okay for us. I have just to film in another view. The best view to see your device is the profile or left inclination of the tube. So if you can push a little bit the echo, I have to. You can pull back the probe here. Donc la meilleure vue pour voir le septum, c'est de faire de l'OAG ou carrément un profil. I will show you. Okay, so here the profile, you can see both discs and with space between the two discs, meaning that we have any anatomical structure between the two discs. Donc ici sur la vue en profil, c'est une vue sécurisante, donc on voit les deux disques, quand je peux regraffer à nouveau, donc on voit les deux disques avec un espace interdisque qui démontre qu'il y a une structure anatomique entre les deux disques, c'est-à-dire que réellement les deux disques ont pris quelque chose. Dans le cas contraire, on aurait eu les disques qui vont se toucher, qui vont s'impacter, et à un moment donné, la prothèse ne tient rien, risque d'embolie. So here we have to retrieve everything and doing manual hemosthesia. The patient will stay maybe for 1 or 2 days in the hospital, and he will discharge maybe after 2 days. Thank you for everyone. For double antiplatelet therapy, we will maintain it for 6 months, and then we will maintain aspirin alone for maybe 5 years. I will show you again in the theoretical part of the presentation. Thank you and goodbye. Thank you for all the team.
Well, it was not a very simple clinical case. Now we are 24 hours after the procedure. We have no local complication. PFO seems to be totally sealed. We perform only transthoracic echo with bubble test. We decided to put the patient under aspirin and clopidogrel, and he discharged 24 hours after. Obviously, we meet, as you can see here in the video, a very difficult PFO. It was a very small PFO. We failed to cross the PFO with a standard procedure using the MPA device or MPA sheet, and then we changed the MPA for the Judkins Wright sheet. It was also a failure, and then we used, as you saw in the video, how we call it, Mullins sheet that we use usually to perform septal puncture. Obviously, we don't puncture here. We use only the sheet, which have a good distal part, which give us a good and very strong contact with septum. And with pushing the wire, we was able to travel the PFO, and it was the clue of this clinical case. Maybe using how we can call it hydrophilic wire was also an option, but in our experience we failed too by using the hydrophilic wire, and we have a good experience with the Millen's sheet that give us a good contact and help us to cross difficult PFO and small PFO. So the clue here was to change the distal part of the sheets, change the form, and use different sheets to cross the PFO. So hope you enjoy this video, and see you in maybe other clinical cases. Goodbye to everyone, and if you have any question or comment, be sure that we will receive your question and comment with, and we will be happy to answer to them. Goodbye to everyone.